Friends, I am Dr. Bansi Sabu, Vice President of Diabetes Asia Study Group. We are holding this webinar under the DSG and IDF Southeast Asia, which we are dedicating to Professor M. Vishwanathan, to whom we consider father of diabetology in India, whose birth centenary year we are celebrating. We have with us our current president of DSG, Dr. Abdul Bashir, who is going to chair very important session, which we are going to have. It is the second day of our meeting, a live webinar, where we have more than 1900 participants who are registered from different parts of the Asia, and some of them are even outside the Asia who are registered. We have maximum delegates from India. We have today two eminent speakers along with one panel discussion today we have planned. To start with our first session, I request our President Diabetes Asia Study Group, Dr. Abdul Bashir, who will be introducing the Mallika speaker. At the same time, we'll be talking about this program too. So now I request Professor Dr. Abdul Bashir, who is currently Director of Buckeye Institute of Diabetology and Endocrinology, BIDE, and is a Professor of Medicine from Buckeye Medical Institute, Pakistan. Over to Dr. Abdul Bashir, who is the President of DSG. Dr. Bashir sir.
Thank you, Banshi. A very warm good evening from Pakistan and India, Southeast Asia, to other colleagues who are living in England or joining from USA. We had a very good session yesterday, two excellent scientific talks from our good friends Shashank and Mohan. One was about glucagon insights, one about the circadian rhythm. Then we had a very good panel discussion with Dina from Nepal, Sharat from Qatar, and Peter Schwartz, the IDF president-elect from Germany. We are looking forward to a very good day session today. And today the first speaker is Dr. Manilka from Sri Lanka. Is a consultant endocrinologist, President Diabetic Association of Sri Lanka, has got lots of publications. We happen to know each other and as friends, meeting in various conferences for so many years. And he'll be talking on targeting glucagon receptor signaling in the management of diabetes. Over to you, Manilka, please.
Thank you very much for the kind words of introduction, Dr. Basit, and nice to see all of you. And thank you very much for the Diabetes Asia Study Group for the kind invitation and the timely topic, I would say. Very exciting, interesting, a lot of new information I found while preparing for this talk. So let me start. Are the slides visible to you all?
Yes.
Okay. So the topic given to me is targeting the glucagon receptor signaling in the management of diabetes. I'm sure you'd have got a background of the past 100 years of glucagon, first discovered by Kimball and Merlin. But of course, this was a sort of a forgotten molecule. It was just a counter-regulatory hormone, but things have been changing. As you know, diabetes is, early years, it was an insulinocentric theory where we thought it was just the lack of insulin or the insulin action which caused the main reason behind diabetes. Then this bihormonal theory came where we observed that there was hyperglucagonemia. When the assays were coming in, people could observe in all types of poorly controlled diabetes, there was a hyperglucagonemia. So it was insulin deficiency and excess glucagon, which were the hallmarks of diabetes. That theory was coming in at that time, many decades back. And more recently, when people were discovering newer actions and roles of glucagon, the glucagonocentric hypothesis came in almost at the same time as the twin cycle hypothesis of Roy Taylor, the most interesting, the liver and the pancreatic cycle, causing, the diabetes and all the metabolic changes. So it's very interesting. So this hypothesis mainly says that there is information or evidence that glucagon, even in the absence of insulin action, is capable of raising the blood glucose level in an individual, causing many metabolic changes that are listed here, which I'll be talking in the next few slides. So there is increasingly we have understood that there is a tight endocrine and a paracrine relationship of these two hormones. As you know, when our blood glucose levels go up, the beta cells will sense that, and it will release insulin. We all know the pathophysiology behind that, and it acts as a key which opens the tissues to uptake the glucose and utilize or store it, and then the sugar level comes down. Along with that, there's a paracrine effect where the insulin will also inhibit the glucagon, which was the usual counter-regulatory mechanism that we know. And when the blood glucose levels are coming down, there is stimulation of the alpha cells in the pancreas, opening up of the ATP-gated potassium channels and the calcium release, all that, and then glucagon is released, and it will prevent hypoglycemia. So there's a tight counter-regulatory and a balance between these two hormones in the body in the normal state. So the people who were promoting the glucagenocentric theory came based on the following evidence. Because we noticed that the glucagon increases the hepatic glucose and the ketone production, catabolic features were present in insulin deficiency. So if the glucagon levels were high, it was noticed that even in type 1 diabetes and even in type 2 diabetics, poorly controlled, there was a hyperglucagonemia, especially postprandial hyperglucagonemia. Then the well-known glucagon suppressors like leptin and somatostatin, when it was given, was able to, in animal studies especially, show to suppress all the catabolic manifestations of diabetes when there is a total insulin deficiency, in under experimental conditions. And when there is total beta cell destruction in a glucagon receptor null mice, that did not cause diabetes. So that was a very interesting and a significant study, I would say, although it was in mice. I think that was a very interesting and a significant point that they are raising. And perfusion of the normal pancreas with anti-insulin serum causes a marked hyperglucagonemia. So this was the pathophysiological basis of this glucagenocentric theory, where they are promoting, saying that the underlying pathophysiology in diabetes, glucagon plays a major role. To prove what I said before, they did these studies in the glucagon receptor null mice, and in normal mice, they destroyed the beta cell cells and showed that the hyperglycemia occurs in normal mice, but not in the glucagon receptor null mice. So that was a very interesting observation for us to think. And then when the same mice, glucagon null mice, when there is beta cell destruction, the insulin levels were high before the destruction, and then after destruction, the insulin levels didn't go up. Similarly, in those mice, even after beta cell destruction, even if you give them glucose, the blood glucose levels didn't go up. So these are things, new information that we have to, points to ponder for us to think again at the pathophysiology of diabetes. Then there were other, mind you, these are all animal, mice or dog, animal studies that I'm quoting here. I have given the reference at the bottom as well. So the main action of glucagon in the metabolic and, in hyperglycemia is in the liver sinusoid. There's a high density of glucagon receptors in the liver, and elevated glucagon levels despite hyperglycemia was observed in humans it was observed in humans plus in dogs to show that when this normal physiology is disrupted, there is a hyperglucagonemia seen in both animals and humans. And the other study, the panel on the right side, the upper panel, is showing significant reduction in hyperglycemia when glucagon is suppressed. These are all the animals, I think mice study, where the beta cells have been destroyed and there is hyperglycemia. And on top of that, when glucagon was suppressed by using somatostatin, they became euglycemic. In fact, the levels came down. So it's a very significant finding. And we know that in humans compared to mice and dogs and other animals, we have a higher density of alpha cells in our pancreas. They say the beta cells are in the middle and, mantle, the alpha cells are covering, and cell mass of alpha cells is more than the beta cells. And here in this study again, insulin deficiency leads to marked hyperglucagonemia. What I said before has been proven by giving anti-insulin serum to a normal mice, and then it shows how it leads to, when you knock off the inhibitory effect that insulin has on glucagon, that the levels of glucagon go up. This is the general pattern, the counter-regulatory mechanism that we know, and the intra-islet, the paracrine effects of these two hormones are also interesting. In hyperglycemia, the beta cells will get stimulated. In normal person, increases the insulin secretion, and the insulin effect will suppress the glucagon secretion. And when there is hypoglycemia and the levels are going down, they postulate around 5.5 millimoles. This the clock ticks in and it turns the other way. Insulin will come down and glucagon response will be more. But in disease states, especially in diabetes, we know differences came with the ominous octet, so many pathophysiological changes, which culminate in insulin decreasing the insulin or the insulin resistance, among other pathophysiological defects. When there is impaired increment in insulin secretion or increased insulin resistance, there is inappropriate elevation in glucagon secretion because it's not working the normal way to inhibit the glucagon secretion from the alpha cell. So there's a tonic sort of a cycle. Tonic inhibition is not happening the normal way, and there is hyperglucagonemia. And the opposite happens when there is hypoglycemia. There is insufficient glucagon response because of that alpha cell resistance, or they say that even in the liver, there can, due to intrahepatic fat, the Roy-Taylor's twin cycle theory, increased intrahepatic fat, the action of glucagon can be impaired, and there will be insufficient response in glucagon secretion to hypoglycemia. So both ways we know the brittle diabetes, even in type 1 patients, we have difficulty in sometimes managing hypoglycemia as well. So now with this new information, this new thinking, I would say information has been there for a long time. We have to think about a sort of a diabetes being a bidirectional disorder or imbalanced bidirectional disorder where there are many factors which stimulates the insulin secretion from the beta cells, including glucagon in a controlled manner, GLP-1, GIP, and there are many factors which are released from beta cells like the islets like amylin, and then others like GABA, zinc, and insulin, which has an inhibitory effect, and that is all disordered in diabetes, and the reverse happens. The balance is lost, so there is excess glucagon and decreased insulin action, which cause this imbalanced bidirectional disorder that we are talking. So all of you, I'm sure you would have gone through the previous lectures. So the glucagon receptor is a G protein coupled receptor, which has acts in different ways through different intermediaries or post receptor mechanisms to ultimately cause glycolysis, decrease glycolysis and decrease in glycogenesis, and increase glycogenolysis and increase in gluconeogenesis. So basically the opposite of insulin that is happening, and it's the glucagon gene is stated as a target gene associated with type 2 diabetes as well. So then people thought, okay, so if all this happening, why not block the glucagon receptor? And which was done in many studies. Different molecules were developed over the years, but surprisingly, unfortunately, there was reduce in hyperglycemia. The effect was there, but there were other problems: increased hepatic transaminases, elevated liver fat content, abnormal increase in LDL cholesterol, increased weight gain, and blood pressure significantly. There was significant rise of blood pressure. So there is much more than, so these receptors are ubiquitous. I would say it's there in the brain, heart, liver, kidneys, and mainly in the other places. So it has, just blocking the receptor, it did not show any gain, although we were able to achieve a hypoglycemia. So I'm not going to read through all this, but it's for you to see the effects, different metabolic effects of glucagon agonism. So people thought after antagonists fail, why not we try like the GLP-1 and the GIP, glucagon agonism. And these were the effects that different studies in animals and as well as in humans that we have identified. So, it's very interestingly, it increases the hepatic glucose output, but of course, it increases the insulin secretion as well and decreases the food satiety or the food intake and increase energy expenditure. But the net result, even in agonism, have been a reduced hypoglycemia or reduction in hypoglycemia, which I'll show you the evidence with some of the medication in the later slides. And the agonism, I have mentioned few side effects, what we mentioned. These were the effects that was seen in different studies. And people noticed that there was a synergistic effect of glucagon with the other incretins. As you know, glucagon is also produced in the L cells and the K cells in the gut as well, in a small percentage. And GLP-1 is the best studied incretin, with medication showing fantastic results in weight reduction, hepatic fatty tissue fat reduction, and glycemic control. So you can see the effects of GLP-1 here, which I'm not going to read in the interest of time, and almost similar effect seen with glucagon. And the GIP has the opposite. It has slightly increases the glucagon level, and it increases the insulin level. It's all pretty similar, and it has synergistic effects. This gave way to the thought dual and triple incretin agonists utilizing glucagon. So these products were developed, and cotadutide, that is the most interesting one which has gone for studies, and there were many more molecules in different stages of. I will show the 54-week study using this twin tretin, glucagon plus the GLP-1, different doses compared with liraglutide and the placebo. You can see, I'm not going to go through the numbers, HbA1c reduction, weight loss, decrease in lipids, all have shown which is compatible or even better than liraglutide, or much better than the placebo. Very promising results, I would say. And then the percentage, the transaminitis, the side effects of glucagon antagonism was not seen here. Actually, it showed a beneficial effect and a huge benefit in the liver fat and the FIB4 index as well. So a lot of promises for fatty liver disease in future, and the percentage in weight reduction was also very impressive. Effect on the lipid profile was also similar, unlike in the glucagon antagonist, where we saw increase in lipids. Then the latest molecule, retatrutide, the triple agonist. You all are all familiar with the dual agonist, the tersepatide, GLP-1, GIP. So why not add glucagon also to this combination? Very promising early results. We have to be guarded with, guarded optimism. But effect on glycemic control compared to dulaglutide, the higher doses are actually even showing better results in HbA1c reduction and even the body weight reduction. So very interesting times. Similar results with lipid profile and even the blood pressure, but these are phase 1, 1B studies. And the triple agonist is in a phase 2 study for obesity. Greater effect, up to 24% weight reduction in 48 weeks. You remember the tersepatide study where it was like 70 odd weeks, and it was nearly 20%. Even it's going beyond that. Additional synergistic effect can be there. Here, surpass 1. Here we see the differences in the glycemic control. This was only 12 weeks and 40 weeks. They are pretty much similar. And look at the weight loss, 72 weeks versus 48 weeks, and 24% and 22, pretty much similar, and even looking even better. And of course, we'll have to be guarded and wait for the side effects and people to analyze, and larger studies are needed for us to adopt this as a blockbuster drug for our diabetes, I would say, to correct all the metabolic defects that we identify in what we call as this pandemic of diabetes. So the twin cycle theory, what Roy Taylor told there, and the Defranco's ominous octet, which we have metformin, this twin, the triple agonist, and SGLT2 inhibitor, we almost cover all the pathophysiological defects associated with type 2 diabetes, with very good outcomes in glycemic control, weight reduction, cardiovascular risk reduction, and liver disease. But it's a guarded optimism. I think there are very interesting times ahead, and Kimball and Merlin might become a household name as Banting and Best in the near future if all these studies come out positively. And we'll, in our armamentarium of tackling this pandemic of diabetes, we'll have a very good results, even treading on the toes of our bariatric surgeons, where we also could medically achieve, 24%, 25% weight reduction in our patients. So, ladies and gentlemen, in conclusion, I would say the pathogenesis of diabetes is evolving. Even after 100 years after discovery, we are discovering new things with glucagon. which is going to be a very interesting time in the future in this sphere, and the insulinocentric theory towards glucagonocentric theory is changing, but we need more evidence and more people to accept this. And the glucagon receptor antagonists, although it proved to have adverse metabolic effects, the incretins and the synergistic effect of GLP-1, GIP, and glucagon agonism is showing very promising results. Future care of diabetes maybe, and the related complications, cardiovascular disease, NAFL is a huge problem, I'm sure, in all our countries. And Sri Lanka, we are seeing an increased number of people going into chronic liver cell failure with diabetes. And this is showing a very promising future for all those patients, although currently no drug has been approved for clinical usage using glucagon. So thank you very much, ladies and gentlemen. Thank you for listening.
Thank you. Thank you, Manilda. Very, very well timed and comprehensive talk. There may be a time for a couple of questions as we are running a bit late. Banshi, are there any questions from the participants?
In near future, are you thinking there will be a dedicated clinical therapy only targeting the glucagon receptor? Or will it be always in the combination? I mean, whatever the phase 2 and the data of phase 1 and some of the preclinical data which you are showing, in near future, I mean, maybe in a decade time, not like immediately.
Yeah. There may be a role, Bansi, but I feel that, I forgot to tell, when you look at the intrapancreatic, the glucagon, the greatest benefit, the effect comes through the GLP-1 receptors in increasing the insulin levels and stimulating the beta cells. It acts through the GLP-1 receptor also. So pure glucagon agonism also might have an effect, but since we have developed a good side effect profile, GLP-1 receptor agonists are also there. I would say to get the maximum benefit of all what I have shown, the future may be a combination of 2 or maybe 3 would be more beneficial, but I'm sure glucagon alone might also have a benefit, but it may not be that great compared to tirzepatide, so that they are trying to do better here. So that's what I think, but let's see, it's very interesting times ahead.
Thank you.
Malika, can I just ask a question?
Yes.
Yes, sir.
Yeah. Now, the evidence has shown that hyperglucagonemia is like a risk factor and pathophysiological mechanism of type 2 diabetes, but the glucagon agonism is helping us to control the glucose. Why is that the hyperglucagonemia is theoretically in the same way does not help us? Is it because there is a problem in the glucagon receptor, like a receptor dysfunction that leads to the both hyperglucagonemia as well as the diaprogenic effect?
Yes, that's a very good question, Prasad. Yes, they found out the antagonist didn't work because there were receptors were ubiquitous. It's there in the heart, other places, kidneys, and the main concern was the blood pressures went up with the antagonist, right? And of course, there is a description of alpha cell hepatic axis. They are talking the most number of glucagon receptors are in the hepatic in the liver, and they say there is an element of with the intrahepatic fat and the insulin resistance, there is an alpha cell resistance as well developing. So there is a fine balance between the counter-regulatory hormone alpha, the glucagon and insulin, plus delicate paracrine balance. So I think it's a mixture of both, these things. And in diabetes, that balance gets disturbed. I think I showed a slide there. So as you said, yes, there is a dysfunction of the glucagon receptor, or what you call as a receptor resistance is also there, but not very well described. There are so many articles giving different views, but I think
if we pathophysiologically think like it should be the culprit, like, because otherwise the hyperglucogonemia, if the receptor agonism is going to help us, should also theoretically help us if the receptor is working properly, isn't it?
Yes, yes. Yeah.
So this may be like a combination of beta cell insulin receptor dysfunction as well as the glucagon receptor dysfunction, both coming together. Very interesting.
Yes. Very interesting.
Yeah.
Okay.
Can I compliment?
Okay, go ahead. We are running out of time, but just carry on. As a small
thank
comment.
you for brilliant presentation. One thing probably most of us can remember that there is a fulcrum, especially for type 2 diabetes mellitus. We are considering the beta cell dysfunction, but we are not considering the alpha cell, apparent alpha cell hyperactivity. This is the main, probably the main, one of the main underlying causes of having hyperglycemia in type 2 diabetes mellitus. So while addressing the glycemic control, we have to address both the arms, the low insulin level in response to glycemic surge and hyperactivity of the alpha cell and the bioavailable alpha glucagon level in the circulation. So if we can capture these two arms, we can have better glycemic control with minimum adversity, and that in the long run can reduce body weight and other benefits we can extract. So this is the main theme probably we can expect from the this incretin-mimetics therapy in the now we are having in our hands.
Yes, thank you. Okay, let's move. Manilka, you want to reply or shall we move on?
I agree with you, but I just want to remind that we showed in mice where the beta cell mass has been destroyed. And when the glucagon is blocked, you got the sugar levels down in mice at least, So that's a very interesting observation, point to ponder for us for future studies. Thank you very much.
Thank you. So now we shall move to the next speaker. The title of the talk is Liver, Kidney and Heart as an Endocrine Organ and Target for Therapies. And the speaker is very well-known Dr. Krishna Shashardi from Chennai. He is the director of Primer, which is Primer Academy of Medical Sciences. He is American board certified consultant in Chennai Diabetes Endocrine Clinic. Many researches to his credit, editor-in-chief, associate editors in journals. I request Dr. Krishna to please take on the topic. Thank you.
Thank you. Let me share my screen.
Just to inform everyone, we have more than 1,100 doctors who have registered and they have logged in. We have registered more than 1,900 from all over the world. But just to share that around 1,100 plus, even we can say that they are.
Can you hear me?
Yes, please start.
Okay. Thank you. This is a very special symposium of the past 2 days for me, simply because one of the heroes that I've always of mine was Roger Unger, and Dr. Unger, who passed away recently. His seminal work on glucagon and looking at the liver itself as the organ where most of the things happen. My conflicts of interest, some of the drugs that I speak about, I may have had some speaking engagements for those. I was sort of, if I were to take this would probably take a few years to give this talk. But what I will do is I will just pass in with the heart and the kidney and spend a lot of time in the liver, because that's where the action is. That's where this is going to be for the next few years. The next decade is going to be looking at diabetes in the liver, and especially its overlaps with MASLD. Just to We don't know much about the heart as an endocrine organ, but we've slowly started realizing that these hormones are present. We know that the heart is the target of therapies, and we have talked about it ad libitum. ANP and BNP are produced and they cause natriuresis and vasodilatation. The other interesting hormone is the GDF15, which is a TGF-beta kind of hormone, and interestingly works at the liver, causes growth inhibition, causes reduction in growth hormone levels also, and maybe a protective mechanism for the heart when things get too big. But really what it does is it reduces the burden on the heart and coordinate heart and target tissue functions. I'm going to stop with the heart here and make a passing mention to the kidney as well, and spend the bulk of my talk on some very exciting stuff on the liver, as I said. Until 2003, we did not know that the kidney was a site of gluconeogenesis. But 30% of the 70 grams of glucose we produce every day is actually reabsorbed from the kidney, right? No glucose comes into the urine. We know that the glucose transporters, and we know enough about the SGLT family now, and that in diabetes that the SGLT mRNA is elevated, the glucose uptake is increased, and there's a change in the tubal media, tubal maximum in diabetes. We've spent hours and hours and days discussing the effects of SGLT2 inhibitors, but the important thing to remember is that what the kidney does and the effects of these drugs in the kidney is a change in the fuel energetics. Sundar Mudaliar, our close colleague and friend, talked about the increase in beta hydroxybutyrate oxidation that occurs when SGLT2 inhibitors are used. But the thing is that this has been always re-looked at. It's quite possible that they work through a particular protein by the beta OHP working at HDAC at the cardiomyocyte, but also working at mitochondrial uncoupling, and I'll talk about it as I go through this talk. Remember this, that the SGLT2 inhibitors may also be involved at some point of time in the TCA cycle. But what we know about the cardioprotection that SGLT2 inhibitors is its effect on the activation of the hypoxia-inducible factors. Remember, metformin in India increases HIF1, but the SGLT2 inhibitors work on HIF2. And in fact, one of the ways to know that the SGLT2 inhibitors are causing protection is to know that the the hematocrit is going up. If the hematocrit doesn't go up, it means HIF2 is not going up, and this patient's probably not even benefiting from the therapy. There it causes activation of SIRT1 and AMPK, and then autophagy is improved. This is predominantly the mechanism of cardioprotection. Also, interestingly, because we are talking about glucagon, I don't know if how many of you have ever wondered that despite the glucosuria, if you remember, they have 51 grams per day of glucose loss, about 200 calories per day of urinary calories, but the weight loss is only about 3 kgs. Why does that occur? Simply because, and there is no greater urinary glucose excretion, also simply because SGLT2 inhibitors increase glucagon. Glucagon is expressed in the alpha cells, and SGLT is expressed in the alpha cells, and glucagon increases when SGLT2 inhibitors are given. So much so for the heart and the kidney. I rushed through it. Let me take a more leisurely stroll on the liver. Look at the liver. You realize that the spectrum of activity of the liver is now looking at glycemic control, steatosis, and fibrosis. On the one hand, we already have a bunch of drugs that work on the liver that we use for diabetes. Metformin, we'll talk about it. The glitazones, the GLP-1 receptor analogs, the glucagon agonists and the triagonists, right? Then the newer agonists, but also some native hormones of the liver, FGF21, farcinoid X receptor, LXR, from my own specialty, thyroid hormone, especially the beta receptor agonists, and a whole bunch of others that we will talk about today as being very important in the liver and are going to probably define how we take care of diabetes in the next few years. Just to sort of start off, remember that the drugs work on the liver. The sulfonylureas work with insulin secretion, but the GLP-1 agonists are working at the level of food intake. We think that there is some more action that's occurring in the liver simply because we now have emerging data showing that SGLT2 inhibitors reduce FIB-4 scores, and we just have an article that's getting published this month, that shows that the FIB-4 scores come down and especially in a combination of glitazone plus SGLT2 inhibitor. Insulin, of course, is very active in the liver. Metformin works at the level of gluconeogenesis. But look at these others, the FRC-X receptor, the glucokinase activators, the antifibrotic drugs, LXR agonists, and of course, the glucagon receptor inhibitors. Let's take a stroll down them. First is to understand that while we've been focusing on PPAR gamma, a lot of work is happening at the PPAR alpha and the pan PPAR agonists. So remember that the PPAR gamma is predominantly working at gluconeogenesis, at lipid metabolism, some amount of thermogenesis. The PPAR alpha works predominantly at the liver and the skeletal muscle. It also works in the eye. Remember, that is why PPAR alpha agonists are useful in diabetic retinopathy. So these isoforms co-activate, and when you reduce the PPAR gamma activity and increase the PPAR alpha activity, there's a greater amount of activity in the liver. So the PPAR alpha agonists, they reduce inflammation in the liver, reduce inflammation and fibrosis in the kidney, improve muscle sensitivity, improve the browning of the adipose tissue from white to brown adipose tissue, increase the insulin production in the pancreas. An example of one of the PPAR alpha, a pan agonist, and remember many of these drugs that I talk about, some of these get into development, some of these go out of development. Here's one of them, which is lanifibranor. Now, lanifibranor is positioned for MASLD at about 1200 milligrams per day, reduces the fibrosis score. It also reduces glucose by about 0.78 to 0.6, A1C about 0.5, roughly about metformin, reduces fasting insulin, reduces HOMA-IR. So you probably are going to see there's already one that's come out, lobeglitazone, but you're going to see more pan PPAR agonists that are going to come in with a greater amount of activity in the liver. The second approach to the liver is actually targeting the activity of glucose in the liver. For example, glycogen synthase is one of the rate-limiting enzymes, and glycogen phosphorylase. So working on these are some new drugs, especially look at BAY43401, the CP36802, and this particular drug, tidal gloves. All of these activate at the level of glycogenolysis and are promising. On the other hand, there are drugs that work at the level of gluconeogenesis. For example, mercaptoplan and picolinic acid is repurposed to work at PEP-CK level. You could have MDB 3.2, which probably is not going to go into the market. But what is going to happen is you're going to see a lot of small molecules, oligosense or antisense oligonucleotides that are all looking at attacking the glucose pathway in the liver. There are some that are in phase 2, many that are dropping off the market, but this is an area that we're going to look at. Glucagon, I've just put this slide. I know we've talked about glucagon for the past 2 days, but this is one of my favorite slides. It tells you what really happens. Remember, this is the hepatic glucose output. Glucagon is here. Remember, there is no diabetes without glucagon. If you knock off the glucagon receptor, you have no diabetes, whether it's type 1 or type 2. The only constant in diabetes is glucagon. When you give glucagon and streptozotocin, there is no, and you knock off the glucagon receptor, there is no evidence of any of the metabolic pathways of diabetes. So glucagon antagonism, Dr. Suman Tilaka has already talked about it. And we just wrote an editorial in a review in the JOD on this. The issue is actually quite simple. The thing is that there is an unacceptable amount of alpha self hypertrophy that occurs when you give glucagon receptor antagonism. However, there are a couple of oligosense nucleotides that are still in development. Many of these are off the market. We are more into glucagon agonism. We'll talk about it. But there are still a few specifically cardioprotective glucagon receptor antagonists that may be just cardiac specific. We will watch this space. This is my favorite molecule in the world. It's called FOXO. FOXO is a beacon that is present in a cell. When there is increased amount of glucose or lipotoxicity, FOXO goes into the nucleus It activates the MODI genes and tries to prevent the cell from undergoing transdifferentiation. By inhibiting FOXO in the liver, you can actually prolong the activity and action and reduce glucose. FOXO modulation is being talked about. There are specific receptors that look at FOXO as a transcriptional activator, FOXO inhibitors that look at both glucose production without lipogenesis. If you do FOXO pan inhibitors, that they cause reduction in glucose production and they cause lipogenesis. And there are specific FOXO syn3Ka knockout inhibitors that work at the level of MASLD alone. So this is an area that is going to continue to happen in the next few years, that FOXO modulation. Remember that if you knock out FOXO in the intestine, you can create pancreatic beta cells. And a stress hormone that is present in the liver that has been talked about and now is present again with a GLP-1 receptor co-agonism is FGF21. It's a stress hormone. It works through this receptor called FGF receptor, along with a co-repressor or co-activator called Clotho. Now, FGF21, when activated, causes weight loss, brown fat thermogenesis, reduction in insulin resistance, and also reduces hepatic lipids. It has a spectrum activity, but what it does is it can be extended, and a long-acting FGF1 receptor antagonist has been in development. We now have a GLP-1 receptor agonist, FGF21 co-agonist, that causes significant amount of weight loss, reduction in glucose, reduction in lipids, and reduction in hepatic inflammation. Another way of improving FGF21 action is like how we do with DPP-4 inhibitors. You can actually prevent natural FGF21 when you give a fibrate along with an FAP inhibitor. It increases FGF21 and increases insulin sensitization and liver protection. Again, what you're going to do is find out is some of these drugs are going to come as cocktails that compound and complement each other's action. So these are the three kinds of FGF21 that are in the pathways. One is the FGF21 analogs that are probably not going to make it to the market. The FGFR, the Clotho receptor agonist, which again is not in an advanced stage, but we already have a GLP-1 FGF1 co-agonist. This is going to be the decade of the co-agonists. So these are the ones in trials. I've talked about them. I won't spend your time on this. The thyroid hormone has been talked about in diabetes for years. Remember that when you have mild TSH elevation, it's a marker of comorbidities and hypothyroidism. But because thyroid is a metabolic hormone, people have been talking about selective use of thyroxine in the liver. One of the ways is using a beta agonist of thyroxine at the level of the liver. It works by a phosphonide X receptor antagonism, induces weight loss, browning of fat, and also reduction in diabetes. So far, I've talked about how to use these endogenous hormones. The next and interesting stuff is something that we are already seeing. The seat of diabetes is the mitochondria. The mitochondrial chain is where things happen. What happens in diabetes is there is a fuel supply that is in excess to the respiratory chain. There is an increase in the mitochondrial dysfunction. There is a cation leak. The ATP-ADP ratios increase, and therefore there's a greater demand. Now, if you can actually reduce the load on the mitochondria, which is by uncoupling it, you can actually improve diabetes. Example, metformin. Metformin is one drug that works by supplying by shifting the supply of NADP, NADPH by inhibiting the respiratory cycle at chain 1 and moving into chain 2. In India, imiglemin is available, which again works by reducing the same thing. But one of the problems that has always been looked at is that when you do mitochondrial uncoupling and reduce the ATP-ADP ratio, one of the things that you're worried about is whether it is going to reduce the problems in the heart. And therefore, so when you do mitochondrial uncoupling, it reduces ROS production, reduces inflammation and ER stress, increases the ADP-ATP ratio, increases AMPK, increases acetyl-CoA and others. But what people are now talking about is doing this only at the end of the liver, because the mitochondria is ubiquitous, it's present everywhere. In the heart, you may actually have untoward effects. Some liver-specific mitochondrial uncouplers are on the way. Lastly, let me talk about glucagon GLP-1R coagonism. What we know is that GLP-1 receptor antagonists are wonderful. They cause life. They reduce the lipids. They reduce the glucose, but they increase the lipids. They increase the alpha cell activity, and therefore they don't work. On the other hand, glucagon actually works by both the glucagon receptor and the GLP-1 receptor. When you reduce the activity of glucagon at its receptor and increase its activity on the GLP-1 receptor, you get very, very salutary effects. There's the good benefits of glucagon, its effect on glucose, but also the good effects of GLP-1 receptor. By using single or by, you can either add these molecules or you can create a chimera. When you create these chimera, you get these wonderful drugs that include, for example, you could have oxyntomodulin, you could have FGF21, you could have glucagon, GLP-1R, and GIP, so tirzepatide, rutatrutide. Each of these are examples of designer molecules where you can harness the benefit of glucagon along with the GLP-1R and one of these other hormones. For example, Phetuin A can be harnessed. FGF21 can be harnessed. You could harness the effects of FOXO. So the next 5 to 10 years is going to be the era of unimolecular polypharmacy that is addressed at the level of the liver. So what I've tried to do is to rush you through some interesting stuff because you've had 2 days of glucagon. I thought I'll give you a peek into what's coming, especially at the liver. And I think these are going to be exciting times for the endocrinologist, the diabetologist, because this is great stuff that's happening. And interestingly, at least about 15 to 20% of these molecules are making up to phase 3, and many of them are hitting the market. We've already have tirzepatide, we're having rutatrutide, the FGF21, the oxyntomodulin molecules are going to come. Some of the mitochondrial uncouplers are already in the market. We're going to have more specific ones that are liver dependent. I have a big hope for Phetuin. I don't know if it's ever going to make it up to the market. Not much hope for fascinate X receptors or lipoprotein X receptors. But this is an area that is going to determine the future. And then targeted molecular therapy is where the future of diabetes lies. That future lies where Dr. Unger worked, and that is at the liver, at the glucagon receptor, at the mitochondria, at the seat of power, as it may be. Thank you so much for your patience. I hope this gave you a sampler into a very, very large emerging area of science. Thank you so much.
Thank you, Dr. Krishna. Thank you for very, very updated scientific knowledge. The platform is now open for questions. Any questions with Dr. Krishna? The event management, are there any questions from the audience, from the participants, please?
No, sir.
Right. We shall now move on to the last but not the least session, which is a panel discussion to be conducted by Dr. Sanjay Agarwal. Sanjay, are you there?
Yes, that's right. Good evening to all of you.
Right. Over to you.
Yeah, thank you very much. And I would like to thank the DSG, Bansi, and the entire organizers for giving me this opportunity to conduct a panel discussion. It's a very interesting panel discussion. I would like to welcome on board our panelists, the first being Dr. Sajida Selim. Let me introduce you to him. He's an associate professor, Department of Endocrinology at the Bangabandhu Sheikh Mujib Medical University at Dhaka, Bangladesh. He's been awarded the fellowship of American College of Endocrinology in 2016 and the FRSM in 2018. He's published more than 134 articles in international reputed journals, and he's also published 5 books in Bengali on diabetes and thyroid disorders, and is a chapter author of 3 internationally published endocrine books. And he mainly is interested in clinical research in diabetes and its complications, prevention of diabetes, obesity, osteoporosis, vitamin D, thyroid disorder, and sexual dysfunctions. Our next panelist is Dr. Abbas Raza, from Lahore, Pakistan. He's on the board of directors of Dilawar Hussain Foundation. He's the Tamga I Imtiaz, I hope got that right, by the government of Pakistan and the president of one of the highest civil award bestowed for meritorious contribution to the national interests of Pakistan. He's part of the Pakistan Endocrine Society. He's the president of the International Society of Endocrinology, which is the term is from 2022 to 2024. He's a past president and founder, vice president of SAFES. He's a founder and past president of the ACE Pakistan chapter. He's a past president of Pakistan Endocrine Society and past member of board of directors of the ACE 2003 to 2004. As a founding member and board of directors of Friends of Mayo. So welcome on board, Dr. Abbas, and I would like to congratulate you. Your team won today. So it's a very nice feeling to have your team win today in cricket. We've got our next panelist, Dr. Prasad Katulunda. He's a professor in medicine, consultant endocrinologist at the Vidya Jyoti National Hospital of Sri Lanka, University of Colombo. He's got the honorary title for Outstanding Scientific and Technologist Achievements, which is the highest national honor for science in Sri Lanka. He's got over 150 research publications in peer-reviewed international high-impact journals, and his research interests are epidemiology of diabetes and NCD, prevention of diabetes and diabetes remission, diabetes genetics, and thyroid disorders. So I think we've got a very eminent panel of endocrinologists today. And I'm just going to throw questions at you and provoke you to give us some insights into what we're going to discuss today on the future of GLP-1 agonists in the era of dual and triple analogs. So let me begin first by understanding that where was the need for bringing in dual and triple analogs? And I would like to ask Dr. Abbas his view on this. That when we were satisfied with GLP-1, then where did the role of dual and triple analogs come into play, in our practice?
And thank you very much for a very nice introduction. And again, it was at last Pakistan made an impact in the World Cup. But again, I hope it's not too late for us. Just to give you the background of it, and I think we've heard about the glucagon and the properties of glucagon. One of my best friends says that the pleasure of having a pie is tasting it. And again, I think that's where we know the GLP-1 did wonderfully well. And again, the semaglutide came in, and again, it had wonderful results, and the previous liraglutide and everything was working out. But then as the desire and the discovery of science evolves, we found out that if you add GIP-1 like tirzepatide, you get extra mileage from it. And again, now as mentioned in the past as well, retaglutide is also on its way, which has a glucagon agonist as well. I think it's very important to know that the effects of and the effects of the glucagon and the combination and the triple regimen comes in when we look at the functionality of how glucagon works. And again, this has been very nicely summarized, explained in the previous talks. But I must say that we still are not 100% sure why are we getting and how come we are getting all the wonderful results in combining all these. And the reason I say this, there's obviously the role of glucagon is understood in hyperglycemia. Its effect on positive ionotropic effect, chronotropic effect on the heart, which increases the heart, is well known to us. And obviously increased energy expenditure is another part of it. Why are they all come together? And when you combine together and having the wonderful results as far as glycemic control is concerned, weight reduction is concerned, and still yet to see with more confidence what would be their effects on the cardiovascular. I think that's where we are, as mentioned in the previous talk as well, we are living in exciting times. I remember graduating from the fellowship in endocrinology from University of Wisconsin in 2003 and 4. The only thing I had was a sulfonylureas, metformin, troglitazone, rosiglitazone, and pioglitazone were in trouble. And again, and the DPP-4 inhibitors came out. And then it was insulin. Now we are living in the time with this new molecule, which is coming out almost on a To answer your question, the interest is that how these novel molecules are helping us. We know partly the reason. We still have to learn a lot in years to come, how these affect, and again, what the cardiovascular data would be coming out with. The retatrutide has a TRIUMPH trial, which is showing very good results. But again, there will be new products which will be giving us better answers in years to come. Over to you.
Great, thank you. Dr. Sahajada, sorry. I just want to ask you a very important question that, when we look at triple combinations of GLP-1, GIP, and, glucagon agonists, do you think most of these effects are driven by GLP-1, or do you feel there's a significant contribution by GIP and the glucagon agonists? So where do you put this? Because we know, as Dr. Abbas just mentioned, that glucagon agonists are potentially diabetogenic, and we are trying to neutralize that by the GLP-1 GIP combinations. So do you think most of the effect comes from the GLP-1 in this, or there's a significant contribution by the other two? You're muted, sir.
For the kind introduction and the brilliant moderation of the program, and the organizer, I must congratulate them for the nice arrangement. Nowadays, the main approach of diabetes management is not the targeting the blood sugar lowering approach. It is also the addressing the in future complications of diabetes. So for this reason, in ketonomimetic therapies now came in the field. But nowadays, we are moving to dual cuttings and now the triple agents in the field. But I must say the main action would be contributed by GLP-1. As you compare the receptors, the GLP-1 and 2, the main line share is coming from the GLP-1. And the main foundations of this therapy, the ketonomimetic therapy, and the previous studies have shown that the main effect, though the effect may not be similar in person to person, in country to country, depending upon the nature of food they consume. Also the genetic makeup may contribute to the effect of the drugs. But the main drug is coming from the GLP-1 receptor agonist activity. So in future, we can see that the GLP-2 or GIP effects may supplement the effect of GLP-1, but GLP-1 will be the main effect in the future. And not only for the glycemic effect, to contribute to the glycemic, extra glycemic outcomes, especially cardiovascular. Now we have proven effect on the renal function, the inotropic, the diuretic, and other functions. So every function, the leader is the GLP-1. So the other effect are not only these three. We can expect that the more ketonomimetic drugs will be in the field, but the main GLP-1 will be the leader in future. We can expect that. But what will happen in science, we cannot absolutely say, but we can expect that GLP-1 will be the leader in the field of ketonomimetic therapy. Thank you for your questions.
Thank you. Dr. Prasad, I want to come back to you. Like, so far, we've had the GLP-1, the GIP, which have been potentially anxorogenic, right? You reduce the appetite. We've never had a drug which sort of increases the energy consumption. And right now, we're seeing a triple combination, which is actually addressing both the issues and addressing the energy balance as such for the first time. Yeah. Do you think that this is going to be a very significant development? Number one. Number two, what do you think the downside effects are going to be in terms of muscle loss and other areas of fatigue and everything that the patient is going to experience? Do you think there would be a limiting factor to use these drugs in these situations?
Actually, thank you very much, and thank you for the organizers for this great symposium. I would just like to start from where Dr. Salim stopped to coming into your question. The thing is, I think none of these we can take and discuss in isolation, because as I think Manilka and the other speakers elegantly showed that there's quite a lot of interaction and crosstalk between these molecules as well as their receptors. So although in the studies there was, when things were kind of tested in isolation, although the GLP-1 showed the greatest promise, when they were combined, for instance, like in tirzepatide, when the GLP-1, GIP was, the agonism was combined, there was tremendously exaggerated response in terms of weight loss and glucose lowering and so on. So I think in the same way, when the glucagon receptor agonism was also combined, things might not work in the same way you would anticipate if they were to work in isolation. So there may be so much of complementary effects, and then a lot of crosstalks sort of like that would happen in normal physiology might be happening. And again, coming to what you were asking, again, I think this quite early stages to predict on some of the other outcomes, but we have to wait and see because the glucagon again increases energy expenditure, and also there are a lot of effects on the cardiovascular system and the heart. So I think we should wait for the long-term outcome data. But having said that, when they are coupled with GLP-1 receptor agonists as well as GIP receptor agonists, so they might work not in the same way where you would increase the glucagon effect, but then again it might work in a different way, and we have to yet wait and see how things might turn around. And initial data is quite fascinating, so we have to wait and see how they would reflect in the long-term studies.
Yeah, Dr. Abbas, let me come back to you. One of the major things, and I asked Dr. Prasad the same thing, that, when we use tirzepatide and now, semaglutide, and we are on the trials with CARGI-SEMA also, you find a very drastic weight loss that tends to happen. You get almost about 18 to 20% of weight loss that is there. But along with the weight loss, you get a lot of muscle mass loss, and which was also very eloquently in the ESD pointed by Dr. Navid Sattar, that this is not actually the muscle loss, it's the intramuscle lipid fat loss that tends to happen as such. Okay. So what do you think? Because a lot of these people who have done the trials for tirzepatide, have done the trials for other GLP-1 analogs, this fatigue actually becomes a very limiting factor, and people get very distressed and they're not able to function. And even when you stop the drug, it takes a huge time for them to come back. Now, this doesn't happen in every patient that you give the drug, but that's a significant problem. So other than the GI side effect that the patient tends to have, this has been a lot of people who have been commenting about the fatigue feeling that the patients do tend to experience.
So thank you very much. I think it's a very relevant question in this time and age. And again, we usually talk about the semaglutide and the liraglutide and all these medication, but we don't usually talk about things which are actually happening in the world. I don't know if we are very familiar with the term called Ozempic face, in which you lose a lot of changes, facial features, and again you look like someone who has lost weight. And again, we don't talk much about the plateau that we see with semaglutide. That also leads to your question that once you lose it, why can't you just lose more? And again, hence losing the intramuscular mass fat also results in a lot of people say that they've lost muscle mass. And honestly, if you look at the muscle strength and other parts of it, that is not gone. Actually, it's just the loss of the fat that they had gives you the impression that they've lost a lot of muscle mass. I want to also share some of the work which was done between the tirzepatide and the semaglutide, in which if you compare, and that is reflecting on the question that you asked earlier as well, is based on the fact that when you look head to head with the effect of GLP effect of semaglutide with tirzepatide, if the GLP effect is matched, you get a much more better. You must get a much better effect on your weight reduction and the glycemic effect with tirzepatide as compared to semaglutide. So the effect of GLP-1 is not only there, the effect of the GIP-1 in tirzepatide actually has a significant impact in the combination of the drug. Because initially when it came out, I wasn't even sure, looking at the data, if it's just a stronger GLP-1, like you get the response from liraglutide, probably semaglutide is stronger, and then tirzepatide is even stronger, and that's why you're getting more reverse response. But when you look at the GLP-1 response, if you match them with the dose that they're equal, the GIP effect is definitely reflecting in causing more weight loss and causing better glycemic control. And I think that's also reflecting in glucagon agonists as well. So I think it's a much complex situation. And anecdotally, there's a lot of other medication which you end up stopping because they don't have the same effect. I'll give you an example of SGLT2. There are a lot of people who lose weight and they feel very fatigued when they're using a medication like SGLT2, and you need to stop it. And I think the same number will happen with GLP-1 and their combination. Only time will tell with this triple agonist how many of these people would not be able to tolerate this triple regimen. It will be exciting to see how many people in the real world data are not able to, because of the muscular changes or the fat tissue decrease in the physiological process.
Dr. Selim, let me ask you a question. That, see, we give a lot of people GLP-1 and not everybody has a response. There are a lot of people who have failure response and non-responders, right? What do you think could be the way, or can we identify the non-responders, number one, by screening them and say who are the people who are going to actually benefit from GLP-1? We have tirzepatide also, and a similar story there with tirzepatide. So how would you sort of deal with non-responders to the GLP-1s?
Thank you for the billion question, I should say. Probably every endocrinologist in different parts is facing the similar problem. Especially in Bangladesh, we are facing the costly drug. And after giving the drug, the patient is enjoying the side effect, but there is minimal pharmacological effect. So many of the patients, we are in Bangladesh, we are stopping the drugs. But probably currently we do not have any specific criteria to select the patient for the GLP-1 or GIP or combination, that this patient will have most benefit and this patient may not. But one thing we should keep in mind that many of the patients may not benefit from this drug. And probably the BMI may be an indicator. The higher the BMI, the outcome is better. So that can be even given to the normal BMI patient, but the effect may be lower. With the higher BMI, maybe the higher the level of weight loss or other effects can be expected. But probably we have to wait for a few more years to have stringent criteria to select the patient who will have the beneficial effect, or who will have the minimal beneficial effect with these drugs of the single GLP-1 or the combination. Thank you.
Thank you. Since we're running out of time, but I'll put a last question to Dr. Prasad, that we're always concerned about the duration of time that we need to use these agents. How long do you think we need to use them? And do you think after stopping these agents, we always has had an issue of weight regain happening. And that's a major issue that, you need to continue this over a longer duration of time. And some of them advocate that, okay, till you continue to get the benefits, maybe lifelong, you need to continue these drugs. But weight regain remains important. Do you think the same will happen, in your opinion, with the tirzepatide? Do you think the same will happen with the retatrutide?
My view is that, if you stop the drug, definitely the more, because you have not permanently changed the pathophysiology of the diabetes and the obesity in these people, more or less the same things would happen, but the time to make the changes happen might be different to stopping sulfonylurea or insulin or something like that, because already people might have lost quite a big chunk of their body weight, and as a result the liver fat and the pancreatic fat and so on. But having said that, again, there's a group of people who would have got the benefit, and where particularly very obese people you cannot expect them to lose weight by just simple lifestyle. But like in bariatric procedures, if these drugs have helped them to lose quite a lot of weight, where they can then sustain with their lifestyle measures. And fair amount of people might also go on with having the benefits longer term, even after stopping the drug. And again, now with all these theories like of a lot of weight loss and muscle loss and so on, they might not be able to be continued on a very long term, continuously. So like what we do in endocrinology, the bisphosphonates, where after giving some time you cycle them with sometimes the Prolia and so on. So we might have to perhaps even think of, if somebody is losing quite a lot of weight, you might take them off and then tied off with lesser strong drugs like metformin, and then even like SGLT2 inhibitors. And if people regain their weight, now you have a very good weapon where you can reintroduce and get them back to their quite sort of normal metabolism. So I think the time will tell us how we should best use these very important drugs on a longer run. And I think I'm quite excited to see, particularly now, sometimes even in our practice, usually the small body size people in our countries, we go into the half or quarter dose of SGLT2 inhibitors sometimes, but they still give quite a lot of, ongoing benefits rather than just simply stopping when they have lost substantial amount of body weight and so on. So the clinicians might have to adopt the best way how they might be utilized in their own patients based on the initial body weight, the response, and the side effects, and taking everything together.
Thank you so much. I think we've run out of time, and I would like to thank our esteemed panelists for putting such insightful thoughts on GLP-1 in the era of dual and triple analogs. And I just would like to sum up the thoughts and say that, look, we've got new molecules on the horizon, and they're going to do tremendous effects. The question is, of course, we need to look at how effective they are, who are the population that are going to benefit. Are these for every population? And should we sort of, identify the subsets that are going to benefit from this? We always have to be mindful of the adverse events that can happen with these molecules, and monitor our patients very carefully. Obviously, the weight loss that you get with these molecules are huge, almost equivalent to bariatric surgery that we talk about. And the question that comes to the mind is, will bariatric surgery be a history of the past? And, will we have more and more people turning towards pharmacotherapies for weight loss? And if so, then, it's going to be a great time ahead. So I'd like to thank everybody, and I would like to thank Bansi for giving me this opportunity to conduct the panel. Thank you very much. Over to you, Bansi.
Thank you, Sanjay. Thank you for nicely moderating the session. Thanks, Abbas. Thank Salim, and thank Dr. Prasad from Sri Lanka. Good have everyone at the right time. And now, Dina just joined. Dina, how are you? Yesterday there was an earthquake in Nepal.
Yes, it's good, sir. It wasn't in Kathmandu, but it was a tragedy, I think.
Was there?
I didn't realize that because we felt it, but it wasn't too much. But I think there have been some.
All night we have done for. So with the 2 days of webinar from DSG, and we could get the people from all across Asia. This is the best part. We could not get many people from east side of Asia. That is, it is always lacking. Me and Abdul always we talk that how we can connect the more people from, but that are we will continue to work hard to get these people also in Diabetes Asia more and more. But I'm very happy that from Qatar to India and from different parts of the Asia, many doctors could join and they could attend the meeting. More than 1,000 of the doctors who are logged in, and were listening to 2 days of webinar. With these few words, final words, I will request Dr. Abdul Bashir for final vote of thanks to everyone from Diabetes Asia. Over to Dr. Bashir, sir.
Right. Thank you, Bansi. I think Professor Azad is here. So I'll only say thank you to you for the very good active organization. Thank you to the speakers, the panelists of today and yesterday. Thank you to the participants. And as had been elucidated by many speakers in the last 2 days, this was a very important topic. And as Peter Shabazz yesterday said that one of the topics which has been neglected, unfortunately, by many of us for one reason or the other. So it was a very great going. And as you said, we are in the mission of expanding DAS across the Asian countries and maybe taking outside it. As you mentioned yesterday, we'll be having the next DSG conference in Qatar in April, and we are expecting ESD to join hands and have a symposium there and vice versa. So I now request Professor Azad, if he is here, to say goodbye. And from my side, goodbye and good night, good evening to all. And hopefully see you all soon in person. We are very in near future having the IDF complications conference, 4th to 6th of December. But again, that is virtual. So hope to see you sometimes in person as well. Professor Azad, are you there? I think he might have left. So
I could not find he is there.
Right.
Dr. Professor Azad is not there.
Right. So
but just
let
to
me
request
right.
everyone, those who are not the member of DSG, please visit our website of DSG to become the member. For life membership, it is only $100. In last week of April, when we have our annual meeting of DSG, already Dr. Bashir had talked that we have the DSG is expanding, and many countries who are not the member of DSG, please become the part of. We will be meeting again online PDF meeting in first.
Okay.
Well,
so thank you all. Bye-bye then.
Our RSSDR annual meeting of is going to happen at Mumbai. So we all the festival labs of RSSDR.
Okay, so time, Banshi, to call it a day. Thank you all. Have a good night, sleep. We were told by Shashank yesterday, sleep is an important part of the circadian rhythm. So have nice sleep, and inshallah, see you all soon. Bye for now.
Thank you. Thank you.
Bye, Doctor.
Bye-bye.
Bye, everybody.
Bye-bye.
Bye.
Recording stopped.